recording now.
Okay. Hi, everyone, and welcome to the Accomplished Brain podcast, where we talk about brain health, chronic neurological disorders, and other current health issues. Andrew Migo is going to start us off kind of reflecting a little bit back on last week's talk about neuroplasticity.
Okay, great. Thank you, everyone, for viewing our last podcast. And it's interesting that an incredible article. So I want to kind of share the article of the neuroplasticity and some of the chemical things that happen with neuroplasticity. I want to show the article, then I want to go back to our course. And it was so interesting that, I was so excited. I think it was like this weekend, I just happened to see this article and I'm like, wow. I'm like, we should kind of put this on share this article with, and this is such a great thing. So I'm going to share this with you. I'm going to share my article, my screen, and look what this are. And then I'm going to go back to our course, right? Because I think it'd be a great thing. And look at this article. This article says turning on the switch for plasticity in the human brain. This is from neurosciencenews.com. And the summary of the article, and I'll just kind of summarize it and then maybe go around a little bit into the article. Then I want to go back to our course and share how some of the insights, right? So summary says glutamate is first released near the AMPA type glutamate receptor. Then it's released near the NMDA type receptor immediately after the first signal to activate the switch for synaptic plasticity. Okay, so it's basically the most powerful substance in the human brain for neural communication is glutamate. It's by far the most abundant and it's implicated in all kinds of operations. Among the most amazing is the slow restructuring of neural networks due to learn and memory acquisition, a process called synaptic plasticity. Glutamate is also a deep clinical interest after stroke or brain injury and neurodegenerative disease. The glutamate can accumulate to outside of neurons and down or kill them. So as we talked about, is the right amount of stimulation is going to release the right glutamate. Now, I want to go back into our course, and I want to share that with you, right? And go back to just emphasize what we talked about last week with neuroplasticity, and we used our course, and I want to use this again. And if you see over here, what does it say here? Peripheral receptor activates that AMPA receptor, which is where glutamate first gets activated, which activates the NMDA receptor, which is the neuroplasticity, right? And then again, glycine, polyamine, and glutamine, which is really glutamine is a precursor to make glutamate, right? And then it unplugs the magnesium. The magnesium allows the right calcium into the cell that stimulates the nucleus. And this happens over a period of 7 to 10 days or 7 to 14 days of doing your brain exercises a couple of times a day. The nucleus makes the protein C5, and then they activate the mitochondria, and the mitochondria is an energy part of the cell, and that allows us to make more connections. The more connections we have, the improved function, we get neuroplasticity. So I thought that article was just a great article that can emphasize a little bit more or kind of reinforce what we talked about last week with neuroplasticity. Right exercise, the right stimulation, the right frequency, and that's what we're all about here. Okay, so great. So I am Jeff. Anything else to add?
No, I think it's always just important to know is, we think of neuroplasticity in such a positive manner, but if things are going in the opposite direction, right? If we have, too much glutamate and we're flooding the cell, right? That's the start of apoptosis or cell death. And just as we talk about neuroplasticity, like building really good connections, you can do the same exact thing going in the opposite direction, really destroying connections in the brain. So I think it's important.
That's a good point. And that's basically what happens is that when you can have plasticity in the other direction, where basically, and let's show that into let's show that into our course, because we have a really, really good diagram. I'm gonna bring that back up again. And I don't mean to be redundant with our course. We love what we've done. And the key for us is we want to help more people. We feel this field of neuroscience and rehab is just such a great field, the impact that we can make. And we just want to help more clients get better, and we want to help more therapists do this work. With if some therapists already know the work and they like to know more about our software. Some people want to learn more about the work, and we have a course. And then some clients want to get work done, either by someone that like us that does it, or someone that we know. So this is all great stuff. We just want to help more people. So yeah, if you look at this picture of abnormal cell, you could actually see up here what basically happens is um, you have, so if you started up here, abnormal cell function over here,
Yep.
you'll see that basically what happens is that you have abnormal receptor activation. So it comes down to the receptors, right? You have abnormal either, and maybe like the problem is the receptor isn't firing at the appropriate rate, or a bunch of receptors aren't. That decreases the ability of to stimulate the NMDA receptor, which then causes an increase too much calcium into the cell, and that floods the cell. And again, probably too much glutamate. And what happens is too much glutamate, too much calcium floods the cell, and we start to lose those connections. And again, Jeff, they call it apoptosis. They call it cell death.
Right.
So we can read the interesting thing over the last 30 years is that we've learned that we can remodel that whole process through neurostimulation, dietary, coupled with supplements. We could replasticize, and we can make changes. And we're seeing it with the clients that we work with. Okay.
For sure.
So we have a really, really cool talk today that I'm really, really passionate about. Um, I'm going to talk about an incredible, you guys can fill in the blank, but I'm going to talk about an incredible doctor that I actually had the opportunity to meet. And he is, and I'm going to actually talk about him and my experience. He is one of the nicest guys that you could, if you ever get a chance to meet. And I've got to meet him on Zoom. He gave me about an hour's worth of his time. And, I have a connection with him now, and I'm looking further to develop my connection with him. I'm going to talk about it. And he's so open. And if at his level, you could be open, I think we all should be open, as accomplished as he is. Um, and I think that our talk, and the reason I'm going to tie him into this talk is because him and I talked about some concepts, um, and I'll share with you how leads into our talk today about mechanism-based therapy and evidence-based therapy. And ultimately, we want all our work to be in evidence, but sometimes the work starts off as a mechanism, and eventually it could move into an evidence base, which helps to get more people to buy in. And what I want to talk about today is the difference between a mechanism and evidence, right? And for two portions. One is a practitioner should be have a very open mind when it comes to therapy, because we know in the last 30 years that the brain can change, and that we could start to make rehab. And I think that we're always kind of learning and growing, and we're looking at things in a little bit different way. And that's how we're kind of evolving, how the therapies are becoming better and better. And we need to have this open mind. And it can't always just be something that was a research. it could be something that could be a mechanism, and we'll talk about it based on the neurophysiology of how things are working. And then people, and we want to talk about that, because I think, one, as a therapist, there's two things. Don't be afraid to dive deeper into the neurophysiology, into the books, and see how things connect, to try different things that are non-invasive, that probably are either going to work and have an incredible effect, or it's just not going to work. There's probably not going to be a harm, but it's just not going to work. As suppose, and also, if for a therapist to look at someone else's work, to maybe take a course or be interested in to learn a little bit more, be inquisitive. Don't be afraid if it's not researched yet, but it's in that mechanism phase. And then for a client who's looking to get better, be very, very open to the possibilities, because you could be working with somebody that has some theories based on the mechanism and is doing some work based on the mechanism, and they're getting some amazing results with their clients that could also help you, that maybe hasn't been tested yet and it became evidence. And that's what I wanted to share today, is that a lot of people are, when they come in, everything has to be, evidence. And the reality is that before it becomes an evidence, a lot of the times it's a mechanism, and it's a theory, and it's an idea, and it's working with a client at a very small level and seeing the result, and then seeing enough of this to saying, you know what, I've seen with 5, 10, 15, 20 of my clients that get better. And I'm going to share this in a couple of different facets. um, when you can, and I'm going to share it in a sports injury case. I'm going to share it in a pure brain case. And then I want to talk about this, because this is a really exciting and interesting topic, is mechanism based versus evidence based. So let's go in, and maybe Jeff could go into give us a definition on what he thinks the mechanism based therapies are.
Sure. So, I think first to just look at the evidence-based therapies, I mean, that stuff's pretty obvious, right? It's like, if somebody's done a study on something of a methodology that's proven, right? For example, like Cymbalta helps with anxiety, and there's been tons of studies on stuff like that, right? When, as in Andrew and I's world, we look at that as, well, if we have somebody with anxiety and we know the anterior cingulate has a lot to do with our shifting thoughts, how can we give the anterior cingulate support in order to help that anxiety? And so when you think of a mechanism based, right, such as that, and first of all, a mechanism is defined as a system of working parts working together in a machine, or an established process that brings about a result. And so when we think about that from neurological rehab, right, we know that left side cerebellum is going to interact with our right side cortex, right? We know that horizontal tracking is going to stimulate not only our temporal lobe, but also our pons, right, in our brainstem. So
If it's a heart, right,
right, if it's a horizontal
right,
tracking.
right.
So we can take these things that, like, well, we know the pathology or we know the mechanism, so why wouldn't that work? And I think we're learning so much so rapidly about the brain, about neuroscience, about pathology, that the studies, right, haven't caught up to how quickly or how deep the brain is. And I think that's one thing that Andrew's done an incredible job with the course, and I've been so lucky to be a part of, is that, hey, here's the pathology, like, here's how the functionality is. And so if we can give support to it, if we can activate it, or if we can inhibit it, then we can help create hemisphericity in the brain, or we can create balance, if that makes sense.
Yeah, yeah,
um,
yeah. And I think, Jeff, that was really, really well said. I think exactly what he was saying is, here's the pathology. So here's what you have, and here's the system of how things connect together. And then we're making an observation, or we're making a good, how do you say, we're making like a good, I wouldn't say guesstimate. I would say we're making a good logical next step would be if, like, if you have a pons lesion. Well, here's a better answer. People sometimes have a pontine nuclear, a pons issue. So they'll have, so then you go back and you look at what's in their pons, right? You could say, well, their facial nerve, their cranial nerve 7, right, which is their facial nerve. So muscles of the face. You could say that, you could say the sensation of their face, cranial nerve 5, which is the trigeminal nerve. You could say they have their vestibular, so their vestibulocochlear, so that's their cranial nerve 8, right, which is balance and hearing. And so all of a sudden you can have, say, something wrong with their face, their sensation, and then they can have something in their, um, they can have, say, a balance issue, right? So now you're going in and you're saying, well, maybe their pons is affected. Maybe there's no pathology, right? So just say that, you go in there and you look at a CT scan and there's no abnormalities with the structure. There's no tumors. There's no vasculature issues. But we know that those things aren't functioning right. So then you could say, well, maybe the pontine area, right? And then we look at like horizontal. So that's one case, right? We know all those structures, like this is mechanism, lie into the pons. We also know that when you're doing horizontal eye movement, right? If you could trace the eye movement to the abducens nuclei, right? Because we know that's a part of it, right? Again, and that abducens nuclei is located in the pons, right? So you're doing this horizontal tracking. We know it's medial temporal lobe. We also know abducens nuclei. We know the pathway, so we know the pons is affected, and we see that they have trouble with tracking their. So if they're tracking to the right and left, their head wants to move. It's a common thing that happens. So we think there's something going on with their vestibulo-ocular reflex, which again in the pons. So then we know that with the pathways, this is mechanism-based therapy. We know with the pathways that we know, and maybe we can. I think I have it in here, and I'm going to bring this up a little bit, right? So I think we have it in our course. Um, this is going to be really cool. So we're going to bring this up a little bit. So I think when we start looking at this is really.
And Andrew, while you're bringing this up, I just have to say I think that's one of the biggest aspects of the course is the visual diagrams that you were able to put together in actually seeing the pathologies. I myself am a visual learner, and how well you're able to put together the neuraxis and basically almost like looking like at the pathways that we were talked about last week with neuroplasticity. I think that's a huge way for a practitioner to learn, but it also actually really helps the client kind of understand what you're trying to accomplish from a practical application standpoint.
Yeah, so watch this. I'm gonna, and thank you, Jeff. And he's right. We put a lot of time into the diagrams. So if you look at this, right, if you want to track a target to the left, look at this. So if you look up here, you have the eyes, you have the cortex, so you have the left and right, like you're looking at the person. So that left medial temporal lobe will fire down if you're doing this horizontal eye movement. So if you're doing this tracking to the left, that left medial, look at this. We got this in the course, which is unbelievable. And this is the mechanism. And we want to explain of how doing vertical eye movements could help the pons. This is like I'm through the roof with this explanation. So you have the medial temporal lobe. So you want to take a target. Here's my thumb. Your eye wants to track to the left. Medial temporal lobe will fire down into the green, which is in the pons. The green is in the pons. The orange is the upper brainstem called the mesencephalon, and the blue is the medulla, right? These are all where your cranial nerves sit. and there's massive amount of function. I'm going to come back to another diagram of how the cranial nerves of the brainstem could affect the memory centers, right? This is just really cool stuff. So you come in and you're tracking a target. The left temporal lobe fires down into the brainstem, right? The adducens nuclei. It stimulates that activates the that's going to activate the cranial nerve 6, which again is also, let's follow this pathway, right? Which is going to activate the medial, which is the medial longitudinal fasciculus, which is just a structure in the pons, and that is going to fire to now the upper brainstem, because what happens is when you're tracking your target to your left, one eye is moving lateral and the other eye is moving medial. So the right eye gets activated by an eye muscle called the medial rectus, which that muscle sits into the upper brainstem. So here's a simple thing, simple thing. We know now that the upper brainstem and the pons communicate with each other. We know that. We could see that right here. We know that they communicate with each other. So with that said, we know that if we strengthen the upper brainstem, you have an issue with the pons, right? And you give them, so you have an issue with the balance. You have an issue with, sensation of the face. So they come in and they do a CAT scan. They go to the neurologist or neurosurgeon. They get a CAT scan. They rule out to making sure that they don't have any vascular issues. They rule out that they don't have a tumor. They rule out there's nothing abnormal with the structure, but they're having something with the function. Like their balance is off. That their eye movement is off, right? All this stuff. You try to give them horizontal eye movement, and that doesn't work. They fatigue, and they just get worse. But we know here's mechanism-based therapy. We know that just in this picture that the upper brainstem in orange and green communicate with each other. We see it here in the pathway. So we know if they communicate with each other, right, the next logical step is we could give them vertical eye movements or head movements vertically. A lot of times now go back and give them a vertical eye movement or a vertical head movement, and now go back and give them that for a week or 2 weeks. You'll start to see, recheck their balance gets better. Recheck to see if their sensation of their face usually will get better. I mean, so again, was that tested and became evidence? No, that hasn't been yet. Maybe that's something that we need to so we have a hypothesis, right? And we said that if you have an issue that you think you have in the pons, and you give exercise in the pons, like horizontal eye movements, that basically people will, might get worse because that area fatigues. And we're going to go over we're going to have a whole podcast on what is fatigue and how to get around that. But now our mechanism is, we know based on this picture in our course, we know that the green, the pons, and orange communicate with each other. Enough said. So now our next logical thing is, let's give them and activate and strengthen the area in orange, because we know green and orange communicate with each other. Almost positive, I've seen all the time, they have an issue in orange, you give them exercises. You have an issue in green, you give them exercise in green, they fatigue. You give them that mechanism, orange and green communicate together, give them exercise. So what would you do? Tracking, head movements, vertical, or tracking vertical. And all of a sudden you go, and a week, 10 days, 2 weeks, a month, whatever the time frame, and you start seeing rechecking their rechecking their horizontal eye movement, rechecking their balance, rechecking their sensation of face. All of it has gotten better. That is mechanism. Now, if you go in and you do a study and you ask, like say I did a study on that, there might not be no evidence that's out there, But I could tell you that in my practice, that I've done that over and over and over and over. And all I have done is, and basically mechanism-based therapies are, I look at the mechanism and I just keep connecting the dots and I keep thinking logically. I keep saying to myself, okay, I could see that in some instances that in green, the pons, and in orange, the upper brainstem communicate with each other. I could see that I have a problem in green. I give the client exercises in green and they fatigue. We're going to go over a whole podcast on what is fatigue and how to get around that, whether it's nutrition, whether it's going to other areas, because other areas communicate just in the, like this example. So then my next logical thing is, I can give exercises in orange because I know that orange and green are gonna communicate with each other. So I know that if I give exercise in orange, green is gonna benefit. And maybe they're gonna benefit at a better rate. Meaning, like, if you lift a weight and if I go into green, the direct area, it's like lifting a 10-pound weight. But they fatigue. They pick the 10-pound weight. It's too much. Or I alter my form.
Right.
Now, when I go in, I might give exercise in orange. And by the time green gets that stimulation, or green gets that benefit of doing the vertical eye movements in orange, that green, it's like lifting a 5-pound weight. And I'm like, you know what? I can do this. I can lift this 5-pound weight. And I've seen that over and over. Now, that's a mechanism-based therapy, right? Now, that's not something that might be researched, but maybe at some point it could become a hypothesis with a scientist, right? Because I have all these ideas that I see that are working with mechanism, and the next step is to get a greater population of people to accept that is a study to become evidence. But what I want people to recognize is, a lot of times before it becomes an evidence, it became a hypothesis. And before that became an hypothesis, it became a mechanism. Somebody saw a mechanism and then they started to try to do that. And they saw it worked at a very small scale. And they started to make it work on a little bit of a greater scale. And then they saw it enough to say, we got to get that studied. Let's create the hypothesis. And then that hypothesis became a study, and that study became evidence. And all I'm saying to people is if you're a therapist out there, don't be afraid to dive deeper into the depth of the neurophysiology. Don't be afraid to dive deeper into that. That's one. And then the second thing is, don't be afraid to listen to somebody or explore somebody who's had a lot of things and mechanisms that down the road, some of those things might turn into be evidence, because you could be missing the boat on learning something and being very open to learn that might be able to help your clients or patients dramatically. The second thing I'm going to say is, if you're a patient and you haven't heard, this hasn't become mainstream therapy yet, but you're still went to all these other therapies and you haven't gotten the result that you're looking for, right? And you're looking for something to get better, to improve your function, and you find somebody that does mechanism based and they sound intelligent, and they explain things in a good way, have an open mind, because that therapy might be able to help you out a lot. And then eventually that therapy might become, a hypothesis to a study, and that study might become now an evidence-based therapy. And that's, and I want to bring something up. I want to talk about two more concepts in this. So that was one with using eye movements. I want to also talk about a couple of things. So there's two things that I want to talk about. I want to bring up another. I want to bring up this article that I read. So I want to bring up 3 points. So one point was using the eyes. The other is using head postures, right? Okay. Now this isn't, if he's out there, I'm going to say to him, I'm going to say I'm promoting his work. I want to get in touch with him. So actually, when I cut this video, I might share that I did a podcast, and this guy is really sharp. And if he's out there, I've left him a couple. I want to share my software, and I want to connect with him because he's a really sharp guy. Actually, I don't know all the people written in this article, but I know of two of them. I don't know any of them directly. I've not met them. I want to meet two of them. Okay. And there's two of them. This is an incredible article on, and I want to share this with you of how I looked at this article from a mechanism and how I started to look at head postures. This is like right now I'm going through the roof. Like Jeff has to come over to my place and calm me down, give me some magnesium, you know?
Right.
So this is one of the gold standard clinical pearls on clinical pearl articles. This is done, and there's four people in this article, and two of them I'm going to mention that are just unbelievable. And I don't know of the other two, but two of them I know of. I don't know them personally, and I want to meet them. Dr. Asif, Dr. Sheikh AG, Asif Sheikh, his name is. He's originally, I think, from India. Super smart guy who's a neurologist. He's done his fellowship. He did a fellowship at Johns Hopkins, and that's where he met Dr. David Z. Dr. David Z is at Johns Hopkins, a neurologist, and maybe the best in the world in eye movements and vestibular brain function and balance. He's got a gold standard book, Dr. Z, with Dr. Lee, called Neurology of Eye Movements. And I'll share with, I've studied that book for 7 going on 8 years. By far the hardest book I've ever read, by far my favorite book, and just incredible insight. I mean, the amount of research and it was put into that book was just incredible. And Dr. Sheikh AG, or Asif Sheikh, he's out of Cleveland, and he did a fellowship, and now at Johns Hopkins, and he does a lot of collaboration articles with Dr. Z. I don't know them personally. I know of them. I have a lot of their research articles, and I want to meet both of them. I want to share what we're doing with the software, but incredible guys. So they wrote this article along with Douglas Crawford and Haida Jinnah, and I don't know them either, but they did obviously a part of this article, which is incredible. It's called Cervical Dystonia and Neurointegrated Disorder. What dystonia is there's a sublayer of the brain, and that sublayer gets affected, and it causes the brain to not know where it is in space, and it causes the brain to contract the certain muscles. Okay, so the basal ganglia has two pathways that influence cognitive movement, cognition, eye movement, the emotional brain, the limbic system, and the motor movements. And one pathway influences to excite those pathways, those direct pathways, and another part of the pathway is relaxes. So they have to fire at the same rate, and they don't. So what happens, you tend to get stuck in dystonia where your muscles are stuck. And in this case, it's cervical. So you get certain kind of cervical patterns, and you get certain kind of cervical postures. So if you look down here in this article, I want to just show you this. Here's the article that looks at the head when certain areas of the brain are being activated. And what happens is usually it causes a head tilt and a rotation the opposite way, or sometimes the same way. And what will happen is 3 things. So they'll have a head tilt, they'll have a rotation. Okay, so they'll rotate left or right. They'll be head tilted one direction, and their eye has a skew deviation, which means that one eye is higher and lower. Based on this article, I took this article, the mechanism of what areas of the brain were being activated, which again, this is one of my favorite articles. And these guys, Dr. Sheikh AG and Dr. David Z, are just, incredible, really bright guys. I took this article and I started to adapt, looking at every client and looking at their head posture, and then identifying based on this article what part of the brain is being activated that puts them in this position, to understand what side needs to be activated, and then a strategy using eye movements or head movements to correct that posture. And amazingly, I've been able to correct so many people's posture without them doing any adjustments or anything other than moving their head, doing vestibular, and using their eye movements, and very specific based on this article. Again, I took the mechanism of these head postures based on this article, and I apply that to almost every client, looking at the part of the brain that's being affected. And then I applied eye movements and head movements very specifically based on this article where the problem in the brain was. And amazingly, very simple things have been able to correct their head posture. I mean,
Right.
that's a mechanism-based therapy. Now, he took this article that was actually researched, and I started to add my own layers into that, my own logic, to say, well, if he's doing this with dystonia, why don't we just look at that's the mechanism. He's looking at that at that deep level, right? The physiology. And then I just said, let's connect the dots, and then let's expand on them and give them simple eye movements, simple head movements, and we could correct postures. And that's why so grateful for these guys and the work that they have done, and this article. Just amazing stuff.
Right. Because the pathology doesn't change. If
Yeah,
if
it's not going to.
dystonia, if those muscles are going to be contracted in a certain way, it's going to create the certain, head tilt, rotation, so on and so forth. And what's the difference with somebody who doesn't have dystonia, but they have no awareness, right? Or they have constant tension on one side. There's no difference. You use the pathology and you apply it.
There you go. And here's the thing. And when these guys talked, when Sheikh AG and Dr. Z and the other two people talked about this, wrote this article, it was based on pathology that they've seen. But I just took that and said, well, what happens if they're seeing it in there? Yes, there's a deeper level of what's causing them to be stuck in that. But the reality is, if they're stuck in that posture, logically, the same area of the brain is being affected. Maybe in dystonia, they have another layer that you have to look at, and activating that, doing strategies to do that other layer. But the fact of, if they're in that posture, there's certain things that are activating the brain. Maybe in this article, the level of pathology is higher, but you could look at everyone then who you can look at everyone's head posture and take those concepts and be able to use then an eye movement or head movement strategy to correct the head posture. And that's what I did. That's a mechanism-based therapy.
For sure. For sure.
And his stuff was evidence based on their stuff was evidence based on the dystonia. And I just took that and said, let's apply that to everyone's posture. Now, is that the case all the time? There could be other things too, structurally, that could put them in certain postures. But I would say a lot of times, neurologically, if you look at that, you could do a lot and correct and help a lot of people.
Right.
So
it's funny because I just want to relate that real quick to the orthopedic world. I mean, if somebody comes in and they say, Jeff, I have pain in the back of my knee, right? You could say, well, it could potentially be ACL, could be meniscus, so on and so forth, right? And you look at it and you have to ask the questions, and you have to take a look, like, what's the quality of the tissue, right? So we know that at the end of the day, that the popliteus in the back of the knee has fascial attachment to the meniscus. So if it's tight or if it's not moving well, it's going to pull on the dorsal horn of the meniscus. We know that same thing with the semimembranous. It has a fascial attachment, right? And so from a mechanism based, right, we know that actually maybe we can release those things, we can mobilize them, right, that it's going to take pressure off of that posterior horn of the meniscus. We know that from a lateral standpoint, that potentially the IT band is just extremely dense, and that person's not transferring force very well when they walk. Or from their cuboid, right, cuboid transverses force in the foot, and that could be transferring all the way up the chain. And so in a lot of ways, those are all direct or indirect connections, no different than the pathologies that we're looking at here from neuroscience, then we say, okay, if we do this, do we get a positive response from it?
Yeah,
Right.
and that's what
And that's
that's exactly the thought process is.
right.
You know the physiology, and then you connect the dots and you just say, hey, if I try this logically, do I get a response? And then when you start seeing, you get one, you get two, you get three. And I have a lot of, again, I'm not and I want to say this, I think the best is getting evidence based, but again, it takes time to get these something like that researched and studied. And that's something that I'm probably going to be working on with some scientists. And I have all these ideas and I have all this stuff. Can we check this to see if that works, to get like to go from being a mechanism to an evidence? I think when it gets to evidence based, it's great because you have an article that was actually researched.
Sure.
But a lot of times, the evidence comes out of a hypothesis, which comes out of a mechanism, which comes out of you just reading and connecting the dots. So sometimes, that's what I said. A lot of things I'm doing, probably maybe in the next 5 years, will be. I'm hoping to get, becoming more evidence based. But I don't just look at the evidence. I look a lot of times at the mechanism, and then obviously I correlate to see, yeah, is there any evidence? And if sometimes there's not, I still doesn't stop me from trying those things and seeing if we can get a response.
Right.
So
I do think, Andrew, that all comes back to being a good practitioner, and that's whether you're a chiropractor, a physical therapist, you're a neurologist, right? You have to take those things because it's honestly, at the end of the day, it's somebody else's research or study, right?
right,
Whether it's through dissecting a body to figure out fascial systems, whether that's magnetic tracing through brain waves, right? It's somebody else's work, but how good are you at applying it? And I think that's one of the things that you've been so great at, is like, well, I've done my work to definitely ensure I know the pathologies, and now I know how to apply it and at what rate in order to solicit a good response.
exactly. I wanted to show two more things, and then I'm going to wrap that up because I think we're doing a great job today, and Jeff is doing such a great job. I wanted to share I wanted to share this, so this stuff. Um, so this is really good. Uh, so yeah, so watch this. This is really cool. Two things I want to share with you guys, and then I want to share, and then we're going to let. I think we've done a great job for today. So here goes back to I'm in this book all the time. It's a great, huge book, Neuroanatomy Through Clinical Cases. Dr. Hal Blumenfeld, who's a neurologist. I don't know if he's still at Yale University, but he was. And I'm going to come back to this one picture here. I think I got an 18. I think I was in the right one. Where am I here? Yep. So I want to go back. Let me go back to this. Okay, yeah, this is great. Um, oh, where is it? It's the limbic. Oh, sorry. Where is the? I had it here. Bedside manner. Oh, I think I got it up there. No, I think it's up here. Hold on. Ah, here it is. This is what I was looking for. There it is. Sorry. I got it. There we go. This is exactly what I want. Sorry about that, guys. Okay, so look at this picture. If you look at the hippocampal formation, there's an area in the hippocampal formation called your hippocampus in your medial temporal lobe. Unbelievable, right? That area is where your memory centers are. So just look at this area. Look at the arrow, right? And you could see that the limbic system fires into the hippocampus center. You could see the brainstem fires into the hippocampus center. You could see the olfactory, which is where smell fires into the limbic system, which fires into the hippocampus. You could see the hypothalamus affects the amygdala part of the brain, which affects the hippocampus. So here's the thing. What's the hypothalamus? Hormones. So what could possibly affect your memory? Just look at this. This is mechanism-based therapy. Smells, right? You could have hormones. You could have sleep, wake up, right? Because it's all affecting the hypothalamus. Your appetite, right? Light, right? Temperature, right? Then the brainstem. What's in the brainstem? Eye movements, light, smell, sound, vagal nerve stimulation, facial nerve, right? Vestibular. It's all in the brainstem. So you're starting to see this is mechanism-based therapies. So you're seeing if you give a vestibular exercise, that can almost benefit the memory. You give a smell, that might benefit the memory. You affect the hormones, that might affect the memory. You affect sleep, so your sleep gets better, memory could get better. This is how Jeff and I, we look at people who have complex neurological conditions. And this is how we go back, looking at it from the mechanism based and then respecting the evidence based. And that's what I kind of want to share with you guys.
Right. And I think this is also like this diagram specifically is a great way to think through something like PTSD, right? If you see something, right, and the hippocampus is involved in memory, that's going to bring up that trauma again, right? If you smell something, right, something coming from the brainstem, that's going to go back up to the hippocampus and bring back that memory of whatever that traumatic event is. And you can see the cycle of how it affects the limbic system, how it affects your hormones, so on and so forth.
Yeah, so I say, look at this diagram and connect the dots. So the hippocampus, and then here's the other thing. Also, where the hippocampus sits is in the medial temporal lobe. What activates the medial temporal lobe? What can we do exercise-wise? Is tracking eye movements. So let's go back in, right? And this is great stuff. Just want to share one thing. So we could go in, and here we go. We could go right online, right? And here we go. And this is what we want to. We obviously bring up our software. We could give a client something like this, right? We could go like this, as simple as this. And we could go in and we could say, hey, we want to do a tracking.
Right. So very quickly as a practitioner, you can go through this and start stimulating pathways for the
You could
client.
start stimulus. We could give a gray background. We could give 2 reps, right? We can give a speed of 3, right? We can now, oh, hold on one sec. We'll go like this. You can give 1 set. Again, we can affect, we talked about the vertical as, say they have something going on in their pons. We want to give them at 6 to 11 because we want to get more of a vertical eye movement. And here they go. They track the target, simple, speed, color, specific angle where we could put the eye, and we could put this right on their phone. So obviously they could see this. This is simple. They could do some of the and this exactly where we're playing on our screen could be those settings could play right on their phone. Customized program. So I want to add one more thing. So about being open. I was lucky enough in the end of November, and now I started to build a relationship with Dr. Robert Cantu. He's a neurosurgeon. He's the lead consultant for the NFL on head injuries. Incredible, incredible, incredible guy. Just give you a little bit about his education. He was undergrad at Cal Berkeley, medical school at San Francisco. He did a residency. He did a residency at Columbia in New York City. He worked in the Harvard Medical Hospitals and then been head of Emerson Hospital for many years. And now he has a concussion center. He does a lot of research on the CTEs. I've been lucky enough to, he gave me a nice amount of time to view my software. Very open guy. I mean, this guy is he's the creme of the crop. He's like the Michael Jordan of what he
Hmm.
does. And for him to give me that time and openness even taught me more. The more I'm successful, the more I'm open and the more I'm humble. And so Dr. Cantu, we talked about, he gets in his concussion center, they get a lot of, they get concussed, and sometimes through the concussion, they get their autonomic nervous system, the heart rate, pulse, temperature, oxygen, all controls the autonomics. They get concussed and they get what they call POTS. It's called POTS, postural orthostatic tachycardia. What happens is, as they lie down, as they stand up in gravity, their blood pressure goes up, but it should only go up a certain amount, and it starts to go haywire and crazy.
Hmm.
So they use physical exercise, which basically what happens is you have a nerve in your medullary area called your vagus nerve, and that vagus nerve can activate your parasympathetic system. And you also have receptors. So you have receptors. That's how we communicate. We have photoreceptors for the eye, vestibular receptors, muscle receptors. Well, you have receptors. They call them baroreceptors, BARO, and receptor. It's one word, baroreceptors. And these baroreceptors, they stretch when they get activated, and that stretch causes the vascular system to dilate, right? And what happens is those baroreceptors can be activated there's baroreceptors and that's why physical exercise does work. There's baroreceptors in the aortic arch where the heart is, and there's baroreceptors also in the carotid sinus of the neck. So that's why we give breathing exercises. In our software, we have a whole breathing program. So that's one thing. The other thing is there's an area of the brainstem called your NTS, and that sits in the medullary area, and that NTS could further pons and kind of medullary, and that NTS could help activate the vagus nerve and the parasympathetic system. Now that NTS will get activated through taste, right? That NTS will also get activated through the baroreceptors in the aortic arch, so physical exercise or breathing. However, the NTS, sometimes you could do vestibular movements. You could move the head laterally. So if you want to rotate left, and at that same side, vestibular projections could fire into that same side NTS, which that NTS could help activate the parasympathetic system to help people with POTS. So the interesting thing is, I've seen that, and this is my talk with Dr. Cantu. Now, I want to share Dr. Cantu's answer. He's an incredible guy. So at his level, he's the Michael Jordan, could be open. We all should be open. And a great, great guy. Great, great guy. I wanted to share that he said, the first thing he said to me, he's never read that in the research, But the thing he did say to me, that doesn't mean that that doesn't exist.
Mm.
So he's saying to himself, hey, let's look at the mechanism. Let's try that. And if that works, maybe now that's something we could do a research study on. And then we could turn that mechanism to being a hypothesis to then being an evidence-based therapy. And I wanted to share, it was amazing that I shared that. And I have some insights that I think could help him, in that way, with the POTS, because I've had some experience with people with POTS and they use my software and they've done really, really well. So I'm excited to kind of talk to him, share how but he was very, very, very open to listening and very, very open. And he said to me, he hasn't read where vestibulars help POTS, but he's like, that could be a possibility. So I wanted to share that with you. And I know I want to keep things at a certain time limit, but obviously you can see Jeff and I are so passionate. We just want to share information and we want to help. And today it's just like, hey, this is what mechanism-based therapies are. This is what evidence. Ultimately, we want to turn a lot of the mechanism into evidence-based. But don't be afraid if you're a practitioner to explore the neurophysiology and come up, and based on the exploring and the neurophysiology, come up with an idea that and try it with your patients. Don't be afraid to follow someone who's doing a lot of mechanism-based therapy, because they might do something and you might learn something that might help your patient. And if you're a client out there that has complex neurological condition, don't be afraid to work with someone like us, who there's a lot of, some of the things we're doing are evidence and some of the things we're doing are mechanism based. But we've been able to help a lot of people with our knowledge, passion, wanting, and loving to help the client. And we have a great software that we can help you guys to put customized brain exercise programs on your phone to help you.
For sure.
Just want to
For
say
sure.
thank you for if anyone's listening to this podcast, thank you for listening.
Thanks, Andrew. Thanks so much for listening to the Accomplished Brain podcast. We'll see you next time.